Welcome to On the Edge of Breakthrough, where hope meets innovation in the fight against cancer.
Hi, I'm Dr. Monty Pal. I'm a medical oncologist at City of Hope, and I'm really excited to bring to you On the Edge of Breakthrough, Voices of Cancer Research. We're going to be bringing some of our best researchers to the table to discuss exciting findings from their laboratories, from their research programs, and really get some great perspectives on what their plans are for the future. Welcome to the podcast. I'm delighted to have here a legend in the field of quality of life and palliative care, Dr. Betty Ferrell. She's been elected to the National Academy of Medicine. She's been given a Lifetime Achievement Award from the Oncology Nursing Society, and she really is a trailblazer in the field. We're so delighted to have her here today to talk about her many accomplishments here at City of Hope and well beyond.
Thank you. Very glad to be here.
My understanding is that the story begins in Oklahoma. Is that right? Is that where you were born and brought up? Well, what originally kind of gave you the bug to get into nursing and research?
I started in Oklahoma and I went to nursing school. And my intent was to never go back to school again. I wanted to just be a bedside nurse, and that was the best job imaginable. And I began my career in oncology, which was a brand new area. I went to work in the summer in Oklahoma, and as a nursing student, and they gave me a little piece of paper to give me my assignment, and that piece of paper said the word oncology on it, and I didn't know what the word meant.
No kidding.
So that would have been 1976, but the hospital had decided that it was time to have an oncology unit. Before that, patients were just scattered throughout the hospital. And so I literally went up to the unit to find out, what is this word oncology? The hospital had decided that they were going to start giving chemotherapy, a new idea. And so therefore, we needed to have all the patients on one unit so they could train nurses in how to give chemotherapy. So that was my beginning. And I then worked for the next 3 years in oncology in one hospital, and then moved to another hospital, still oncology. And it was a amazing time to be in the really early days of oncology. But I also realized that to do what I wanted to do, to improve care, to advocate for patients, I needed to go back to school. And so I went back and got a master's degree, again, swearing I would never go to school again, and then realized I wanted to do research. That research is the way to change practice. And so I got my PhD. And then a few years later, it was time to come to California and to really find my place where I could do the research I wanted to do.
Amazing. And that first stop was at USC for a year or two, and then to City of Hope. Is that right?
Right. I came and taught at USC for 2 years, which I loved. But I also found the research was going to take a back seat, that my priority there was teaching and then just a small amount of time for research. So I had this amazing, amazing opportunity to come to City of Hope. At the time, there were 2 researchers in nursing research, Marcia Grant and Jerry Padilla. And the 2 of them had really started work in quality of life. And Jerry Padilla was then going to move to another position. And she contacted me. She had been a mentor and said, "Why don't you come here?" And so I thought, wow, this will probably never happen, that I'll get an opportunity to do full-time research and to pursue this thing that I've heard about called quality of life. So that was 1989, 36 years ago, I came to City of Hope.
Oh my gosh, wow. And we were sharing a little bit about what the campus looked like back then. So this was really curious to me. We just have this brand new building that we're now practicing in, which is 8 stories tall, offers beautiful views to patients who are getting treatment. But there was a policy against that back then, right?
Right. So at the time, City of Hope was like a very small town. It's hard to even describe how different it was. But I remember when I first came and getting the tour, and I remember being told there will never be a building on campus more than 2 stories tall. It's absolutely forbidden. We want the patients to be able to have a clear view of the mountains. And this was before the new hospital. It was the very earliest days of BMT. Outpatient was sort of a rare thing. And everything about City of Hope was different. But, what I do remember, and probably the reason I came to City of Hope was also in that tour, someone taking me to the Golter Gate.
Okay.
And so amidst what seemed like a very small town, this very small community at City of Hope, was this gate in the garden that said, there's no profit in curing the body if in the process we destroy the soul. And so I thought, well, this is exactly where I have to be. They built that gate just for me because that's why I'm here. That's what I want to do, is to work at a place that really understands there is the physical body that we're caring for, but this is a whole person. It is about care of the soul.
So well said. I have to tell you, there hasn't been an episode yet where that phrase hasn't come up. It's so powerful. And it really does have, I think, a profound influence on all the faculty or all the staff, frankly, really, doesn't it? You started here at City of Hope at a time when I think the field of nursing research, quality of life research was really quite nascent. Am I right? How did the body of research that was existent at that time look, and how did you get sort of catapulted in this field?
Sure. As I mentioned, Jerry Padilla and Marcia Grant were here to start the Division of Nursing Research, and their work really began thinking about the impact that cancer care was having on patients and families. And so one of their very first studies was done on patients that were needing to have tube feedings. And they began to say, you can look at tube feedings and say, oh, this is a way to get nutrition, to get calories in someone. But then you can't ignore what that really means to patients and families. What is it like to have tube feedings? What is it like to be a family caregiver managing that tube at home? What are the psychological, aspects of being so sick, that you can't eat? And so that began the work in quality of life. And they began a study, and they were really some of the first people to ever use that word, quality of life. And so when I came to City of Hope, this was way before there was a field of palliative care, and my interest was pain management. And so when I came, my interest is people in pain. And we can measure someone's pain. We can say on a scale of 0 to 10, how much pain do you have? But that will tell us something about the pain, but it won't tell us the story of the real person in pain. And so I met with Jerry Padilla, literally at a conference. I think we pulled out a napkin at the table and started drawing pictures on that. And as I was trying to explain to her that I thought pain was more than a physical symptom, that pain affected the whole person. And that's when she showed me their initial quality of life model. And that initial model had 4 dimensions of physical, psychological, social, and function. It was like, wow, to see there was a place for my research, that we really could begin to tell the story of how pain impacted patients' lives. And so I started using that model. But interestingly, as all science evolves, after I did the first study, we also saw there was a missing piece. And the missing piece was spiritual. That we took the functional part and put it in with the symptoms because they were so closely related, but we began to have patients talk about spirituality. And so we revised the model so that there is now a 4th dimension of spiritual well-being, and that model has persisted now for my 36 years here and has been very much a part of all the studies that we do now, to think of the physical, the psychological, the social, and the spiritual.
I recognize those dimensions as I look across the phase 2, phase 3 studies that I'm participating in. And kidney cancer, for instance, I see that reflected in quality of life metrics. And it's just so cool to think that the genesis of all that came from the work that I think you were a really foundational part of. One thing that I think you've done so well is really integrate all of the various departments that we have here at City of Hope. One could really sort of stay confined to their body of work and try to do it independently, but you've really bridged a lot of gaps here between different groups. I think one of the places that started is in our very sort of storied bone marrow transplant group. Is that right?
So 1989, Marcia Grant really was first interested in the BMT population. Talk about a field that's evolved. I mean, these were really difficult times. And patients were in the hospital a very long time, months and months at a time. And treatments were really difficult and side effects were very, very difficult. And so Marcia really started that first study and I sort of tagged along. And it was powerful to be able to work with other clinicians, the physicians that were, world leaders developing the best in care for hematologic malignancies. But for us to be able to say, let's really understand, the human experience. What is this like for these patients to come here and to go through these treatments? And also, we always include the family. And so what is it like for families to live with this incredible uncertainty about what's happening?
Yeah, the surgical data is really quite interesting because oftentimes we think of surgeons as looking at 30-day outcomes, for instance. Did the patient have any immediate complications from anesthesia? But there's so much more to it. The ostomy issue and gastrointestinal surgeries is really key. Give me a flavor for how surgeons have integrated in specific areas of research. Anything in particular you might point to as being case examples that other surgeons might follow?
I think our quality of life model really does guide that work because probably all of us start with the physical domain.
Mm-hmm.
What physical symptoms is the patient having? Why is this surgery indicated? And so we start with, well, this patient's going to have surgery, obviously to treat the cancer, but hopefully to alleviate pain or nausea or bleeding or whatever the physical symptom may be. But then we also realize that those physical symptoms are causing other problems, right? If you are having pain, it means you can't be a part of your family, right? And so when you really talk to patients and say, what is important to you? It's because of my pain, I can't hold my grandchildren anymore. Right? Or I'll always remember one of our studies, it will always stay in my mind. We were beginning to study the problem of fatigue. And I'd been doing pain studies for a long time, always talking about quality of life. And we were going to start studying fatigue. And someone said to me, oh, please tell me you're not going to try to talk about quality of life. Fatigue is fatigue. The patient's tired. And so, of course, I had to talk about quality of life. We measure quality of life, but we also do a lot of qualitative work because you want to hear the patient experience, their story. The very first patient in that fatigue study was a woman with ovarian cancer. And so we asked that first question, what is it like for you to have ovarian cancer? But what is it like for you to have such profound fatigue?
Okay.
And so this woman was probably about 40 years old. She had 2 little children, and she looked right at us and she said, until a few weeks ago, when she was diagnosed with her cancer, she said, very proudly, she said, I was a soccer mom. And now I get out of bed in the morning and I walk across my bedroom to the sink and I brush my teeth and I'm so exhausted I have to go back to bed. So you want to know about my fatigue? She said, fatigue wastes my time and my time is precious. We can talk about chemotherapy and fatigue as if it's a physical symptom, or we can listen to this patient and say, fatigue meant she couldn't be a mother.
Yeah.
Fatigue was a reminder that maybe she wasn't going to survive, right? So that should guide our care. Fatigue is not just what can we do to give her a little more energy. Fatigue is listening to what that feels like as a 40-year-old mom. It means if we're going to really take good care of this patient, yes, we want the best that medical oncology and surgery can offer, but we need social work and psychology and chaplaincy to care for this whole person. That's what the Golter Gate means.
Absolutely.
Right?
Absolutely. You're getting into this space that, I think about all the time, which is that patient with advanced cancer where we're trying to make these very complicated decisions. More therapy, does it necessarily mean more quality of life? I think it's oftentimes very questionable. And there's probably no place that comes up more than in the context of phase 1 clinical trials. Just for the audience, these phase 1 clinical trials are oftentimes the setting in which we're testing a drug for the first time. The toxicities may be real unknowns in these scenarios. And oftentimes, in order to qualify for a phase 1 clinical trial, not always true, but patients will have exhausted many of the existing standards of care. And this is a place where I feel like your research has been particularly impactful. You've been collaborating with Vincent Chung and others in our phase 1 program for many years now to really sort of better understand that experience of quality of life in these early phase studies. And I wonder if you could tell us a little bit more about that.
I think this is really why City of Hope is a special place. People come to City of Hope because we are the leading edge when it comes to new cancer treatments. It really brings all the forces together, right? They know that they are going to get the best, that surgery and radiation oncology and medical oncology, they're going to get expert nursing care, that we have a whole team of people to take care of them. And so we do a lot of experimental treatments, early phase treatments. So over all of our studies over the years, I began to see in our data that who were the patients that needed the most help. And consistently in our own data and data from around the world, it was patients on phase 1 trials. Because these are patients who often have more advanced disease. They're people who have exhausted other therapies. And yet they're people who still are very hopeful. And they also are people who want to help us advance science, right? So many of our patients on phase 1 trials say, I don't know that this will make a difference in terms of my outcome, but I want to contribute to better care. So please learn from me, right? So it's a unique group of patients, and they're patients who often have been treated already with a lot of modalities, but they come here because they want to be a part of really the best that science has to offer. And so it always made sense to me that if these patients are coming here to contribute to advanced science and to get the best that cancer care has, like, shouldn't we be providing them the best care that we have in all dimensions of quality of life? And so we started working with Vincent Chung, a wonderful, wonderful medical oncologist. He is the quality of life model. He is a brilliant scientist, a brilliant physician, and he is someone who really cares about the patient's physical, psychological, social, and spiritual needs. We started doing studies together. We were fortunate to get a large R01 that we did together. And as with all research at City of Hope, ultimately, it's not just about impacting care here, it's about impacting care everywhere for people with cancer. So it was wonderful last year, 2024, to see that because of our work and similar studies around the country, that ASCO now has as one of their 6 recommendations in their palliative care guidelines, the care of people on phase 1 trials.
Oh, that's
right?
awesome.
It's wonderful. And we're so appreciative for the clinicians here who helped to really change that paradigm, right? Because now it's ASCO's word saying these people need better care. And so now we're on the way, right?
Beautiful.
It's great.
Beautiful. I'll tell you, Betty, this is something that I think about all the time. I had 26 patients in clinic yesterday, and 3 were patients where I had very difficult conversations around hospice. One, is a patient that I've seen for 19 years, the whole time that I've been at City of Hope. And, it really, I think, took a bit of a mental toll on me. Do you think we're ever going to get to that point where we can use quality of life data to really help make an evidence-based decision regarding whether or not we should sort of take that leap towards hospice or perhaps direct that patient to a phase 1 clinical trial? Is there sort of a metric you might envision that we can use to sort of steer that decision-making?
I'm always the optimist, the eternal optimist, and I always try to remind myself, because it's easy for us to wake up today and say, things are a mess. We're not doing so well. But I do try to really remember how far we've come, and we have really come a very long way. I told you I started in Oklahoma in oncology in 1976 as a student before I graduated in 77. And that first day when I went up on that unit with that little piece of paper to find out what was oncology, I got up the elevator doors opened. I still didn't know what oncology meant. But there were all these people shouting at each other. And so I thought, well, I still don't know what it is, but it's an exciting area. Well, the excitement was the engineers had been sent to hang the sign on the wall that said oncology unit. And everybody walking by, doctors and nurses, were saying, you can't hang that sign up.
Oh.
We can't say that word. People will know they have cancer, right? So I have lived through, and I've been in many other countries doing our work where we don't tell people, we don't talk to people, we don't tell them the truth. We don't tell them they have cancer. So we have made a lot of progress in terms of being honest and telling our patients their diagnosis and their stage of illness and our best understanding of prognosis. And from that, we have learned that helps, right? Patients need to know the truth. And so when you, as a physician, tell your patient, I'm so sorry, the latest scan shows that the chemotherapy hasn't helped. And as you know, we've tried phase 1 trials, we've tried all the options, and unfortunately, your cancer isn't responding. That's what the patient wants from you. They want honesty, and they want to know that you're still their doctor, right? And so when you say, in the same way I've cared for you to try to beat this cancer, I'm going to be there for you, and City of Hope will be there for you, and we have palliative care, and we have these wonderful chaplains and social workers and child life specialists to help you tell your children this news, that's what good care looks like. And so, yes, we all still struggle because we don't want to say hospice and we don't want to say end of life and we don't want to say death. But quality care will always mean that we are there for the patient for the journey, right? From diagnosis to long-term survivorship or cure, but also for advanced disease, and even when that means the end of life.
It's so interesting that you mentioned the progress that's been made in oncology. There's probably no better field within oncology that I can think of than lung cancer. Recently, there's been this explosion of targeted therapies and so forth. When I look back at some of your pivotal papers, I see a lot of collaborations with lung cancer experts, both here and elsewhere. And it came at a very good time, I think, right? It came when this explosion of therapies was happening. How do you perceive the role of palliative care, of quality of life assessments in the context of lung cancer? How has that helped sort of shape the field?
It's been so wonderful. And I owe all of my opportunities to work in lung cancer really to Dr. Mariana Kozuas, who was a new medical oncologist here. And I met her probably still in fellowship and soon after. And, she was such a passionate physician as a medical oncologist. She was amazing. And so she wanted to work with us to learn about quality of life back when most all of her patients were stage 4 disease and would not survive long. And so we began to do studies and we began to really understand quality of life for these patients and families. So we were understanding dyspnea and the impact of difficult breathing on quality of life. We were looking at nutrition and cachexia. We were looking at depression and anxiety for people, who had such difficulty breathing. So whole person care. And then, of course, treatment started changing. And so in 2000, I worked closely with her from the time she came, but in 2009, we were fortunate to get a program project grant funded by NCI. And when we started that grant, there were 3 different projects. And so we realized, wait a minute, the needs of many of these patients who were now going to live with lung cancer, be cured of their lung cancer, or certainly live with their cancer for many, many years. Those are different needs. And so we did one entire project, what we called early stage. We did another entire project called late stage. But again, even late stage was changing. People were living for years, on our studies. And then we also did a whole project on family caregivers of lung cancer patients. So that was that ran from 2009 to 2014. And so we were studying lung cancer at a time that lung cancer treatment was unbelievably changing. Fred Granis was the surgeon who we started working with. He was going to retire shortly after. Fred came to me and said, I'm stepping down, but I've got these 2 young guys coming from Houston, Dan Rez and Jay Kim. So we said, great, come. And so I think their first day here, I'm not sure they even, knew where to park yet. They came in and we said, you're on. And so again, look at the amazing history, because now 2 incredible thoracic surgeons, wonderful researchers, and, 2 people who embody what it means to be wonderful clinicians and wonderful researchers who every day practice quality of life care and are changing the face of lung cancer.
It really has been a situation where the torch has been passed, hasn't it? From one generation
sure.
surgeon to the next, medical oncologist to the next.
Yeah.
I have to share a story with you, and this I'm sure is really going to validate in some respects all this tremendous work that you've been doing. I remember when there was this tidal wave, the sea change in lung cancer therapy with targeted agents as opposed to conventional chemotherapy. I was in Mariana's clinic as a fellow, and I remember seeing a young 45-ish-year-old Asian female with metastatic lung cancer who had a beautiful clinical response to erlotinib. And this is an EGFR-based targeted therapy. It was just coming out at the time. And I remember scratching my head and thinking, gosh, how is this happening? Chemotherapy would have only yielded a couple of months at best, but she was doing great 3 and soon to be 4 to 5 years into therapy. But, your work has had such a profound influence in the sense that I remember your team being there, right, in the clinic room with her and thinking beyond just about the immediate side effects from the treatment and really digging deep and saying, well, how's life with your kids? What's the interaction like there? How are things going with work? Are you meeting your financial needs, spiritual needs? I remember all of this coming up. The impact has been so profound in the sense that we are now tasked not just with caring with the patient who responds well to therapy, but also evaluating whether or not their holistic needs are being met. Beyond the collaborations with the thoracic surgeons, one thing that I learned about in preparing for our session today is the work that you've been doing outside of the country. And you alluded to this a bit earlier with Lesley Taylor, one of our terrific breast surgeons. Can you tell us a little bit more about that? I think the audience will really appreciate this.
Well, for many years, we've been doing palliative care work around the world through our LNEC project, End of Life Nursing Education Consortium. And so a few years ago, I got a call from Lesley Taylor, one of our breast surgeons, and someone had told her that we did international work. And so we got together and she told me about the work she had been doing since she was a fellow in New York with breast cancer in Ethiopia. And here's this incredible breast surgeon who has, a heart of gold and whose skill as a surgeon is equally matched by real compassion to not only care for great patients in Tuorti, but what's happening with breast cancer care in Ethiopia. So we've been working together for a few years now and doing a number of projects, training clinicians in Ethiopia on how to overcome some cultural barriers and get patients from rural villages in Ethiopia to come and be screened. Lesley is the perfect model of also team science because, for example, in the country of Ethiopia, 110 million people, there were 2 radiation machines in the entire country. And so Lesley spent years, and I sort of joined in a midpoint of advocating to get a radiation machine in the third of the country, where we're involved with Hawassa Cancer Center. Through her advocacy, there was going to be the first radiation machine in this third of the country, 30 million people. But then she realized that getting a machine there meant we had to train them, right? And so a team came from Ethiopia to City of Hope. Again, our radiation oncology department, open arms. How can we teach you? How can we teach you how to do the treatment? We flew them here. We flew them over to Las Vegas so they could learn how to fix the machine when it breaks down because there won't be anybody there to do it. And so now that work continues. Lesley has involved many people here at City of Hope, and they now do a tumor board with the clinicians in Ethiopia so they can present patients. Our surgeons and oncologists and radiation oncology can all provide their expertise. And so We're launching some new projects there now. We're about to start. I was just on a call yesterday to train lab technicians because there's only one pathologist for this region who can only come every few weeks and do so many needle aspirations. And so how can we train others? Because women can't get good care unless they can get a good, accurate diagnosis. So we're doing a number of projects in Ethiopia and mentoring students, master's students, doctoral students, physicians. All of that makes a huge difference in the lives of people in Ethiopia. But it's all led by Lesley Taylor, who is, we're so fortunate to say, is a surgeon at City of Hope.
I just think it's incredible what she and you are doing out there. And one thing that always comes to mind, I've had a number of postdoctoral fellows and others from low middle income countries that have come to work with me. And upon going back, there's this spectrum of skills that they can apply with the resources that they have, right? Oftentimes they're not able to perhaps give the latest in terms of therapy. It might be a generation back, right? Oftentimes in terms of surgical resources, they really have to prioritize who they treat and who they oftentimes will perhaps defer treatment for. It's so hard for us to push the agenda of quality of life and palliative care here in the U.S. as it is, right? How do you do that in a resource-strapped country?
So the LNEC project that I lead has now been in 115 countries, and I've had the opportunity to work with most of those people, but to go into some of those countries. And when we go into a very low resource country, we do a lot of work in India, a lot of work in Africa, all around the world. But we start with a philosophy of strength, right? What are you doing? We want to lift up the local leaders. It's never our job to go in and say, you're not doing a good job or, wow, you're way behind. We go into these countries to say, you're wonderful, and how can we support you, right? I'll tell you sort of a little example, though.
Nice.
I was in Kenya and in Nairobi, and I was in a hospital, and I was making rounds with my team. We were there to do education. The first thing, we go into the wards, and these are people without food or water. We're very close, a few miles from one of the second biggest slum in the world. I mean, this is a different situation, right? And we were going to make rounds, and so my good friend and colleague that's been on many of these trips with me, we were standing at the bedside, and this patient, they're cots, they're very small, very small cot. And as we were looking down at the one patient, we noticed there was all this movement in the cot, and we thought, what's going on, here? Well, what was going on there is there are actually two patients in the cot. And they, one with the head one direction and the other, because two bodies on this little cot. And then there are many other patients in the floor, right? Because there's not enough cots. But as we were making rounds and we were talking to these wonderful clinicians who are as wonderful as our wonderful people at City of Hope, these are incredible people trying to care for their families and neighbors. We kept asking about chemotherapy because they were very excited to tell us they're giving chemotherapy. And we were trying to, again, be only supportive and positive, but, you have to ask these questions. So we were asking, well, what kind of chemotherapy? This is a woman with breast cancer. What kind of chemotherapy? And they would just say, chemotherapy. And so we'd say, oh, okay. So this went on throughout rounds, and we asked several times. And again, they just kept saying chemotherapy. So at the end of rounds, they said, do you want us to show you our chemotherapy? Because I think they didn't understand why we kept asking, what chemotherapy. And we said, yes, that would be great. So they took us, to another floor, into a room, and we walked in, and there was a refrigerator, and they opened the refrigerator doors, and there was the chemotherapy. And that's when we realized, what chemotherapy did they give? Whatever chemotherapy they had. And what chemotherapy did they have? Chemotherapy that had expired somewhere else, right? So you can panic and say, that is really not good care, right? Like, what? Or you can say, I hope there comes a time when these people have better options, right?
Yeah.
And now maybe we could talk about what chemotherapy you have and when you're trying to decide who to give it to. And then maybe we can start where you are, right? And, I can remember being in another really low income, very low resource country where the people, quote, getting chemotherapy were laying outside on sort of a cement slab with a kind of like a clothesline, the only place to hang the chemotherapy. So wherever you go, you start with good intent and goodwill to lift up whatever is happening and to learn from them, because we do learn a lot from people in these countries. They know a lot that we don't. And then now we have the privilege of knowing people for a long time, right? Like Lesley Taylor, as a breast surgeon, has seen things get better in Ethiopia because of her work. And so when we invest in people in low resource countries, the privilege is ours because we see care gets better.
Absolutely. And it's that premise of, you bring up the example of chemotherapy, something being better than nothing. I think that education plays such a vital role there, because there are cases where perhaps the best course is palliative care. Perhaps the best course is a focus exclusively on quality of life. I've got to ask you now about ELNEC in more detail, because this is a remarkable program. I had no idea about the reach that it had. 1.5 million individuals who have been trained through this. Is that right?
Right.
Yeah. Tell us more about the curriculum, what it entails.
In the year 2000, I received the first funding from the Robert Wood Johnson Foundation to create a curriculum to train nurses in palliative care. And so we started with blank pieces of paper, I always say, because what should we teach, right? Again, our quality of life model, kicked in. And so, let's start with the physical. We need to teach pain management, symptom management, but let's go beyond that, psychological, social, spiritual. So we created a curriculum that covers the whole spectrum of quality of life. We start with structures and processes of care. How do we deliver the care? And then we move into pain, symptom, psychological, social, spiritual, and care at the end of life. So we created this curriculum, and our initial grant was to do 5 national training courses in the U.S., as if that was going to solve all the problems. Our work would be done, right? So we did those 5 courses, and clearly we had a very long waiting list because people around the country said, please let us come. We need this. So we just kept going and kept getting more and more funding, and just kept it moving. From the very beginning, I remember vividly that day as we were talking about all the things we could do. And one of my colleagues at the table said, someday we could even do this internationally. And I remember I was so overwhelmed with how in the heck we were going to deal with the whole United States. I looked at that person and said, oh, no, absolutely not. No, we have enough to do. But beginning with our first course, then we started getting calls. So that was year 2000. 2 months ago in January 2025, we celebrated our 25th anniversary of the ELNEC project. Last week, we did our 316th national or international training program. So from the beginning, ELNEC has been what we call train the trainer, meaning we bring people to our course and we train them in the content. How do you manage pain or symptoms? But we train them how to teach others. So we have now trained a little over 48,000 trainers who have all gone back to where they work or their communities, and they've trained others. So we now have over 1.5 million clinicians who have been trained by our trainers across 115 countries and growing. And the work continues. It's amazing to see what good people with passion do. And again, we've been in the poorest of the poor countries and high resource countries. And it's amazing whether you're in Tanzania or the Philippines or India or wherever you are. There's also a lot in common. Like, it's still somebody's mother. People still care about the same things. And so it's also phenomenal to me how a curriculum can be so relevant in every corner of the world.
Oh, indeed. I mean, it's amazing. These milestones are incredible. Congratulations. 25 years. I didn't realize that. It's
Yes.
remarkable.
Yeah.
Remarkable. And you've done this great training on a worldwide level, frankly. One thing that I'm just curious about, and every person that sat in this chair, I think, has been incredibly motivated, talented, has brought so much to the table. I do feel like there's some contribution of the institution of City of Hope. What's your perspective on that? How much of the success that you've encountered here has been really just because of the resources and opportunities provided by the institution?
I think it's all about the people, right?
Mm-hmm.
But the institution creates the environment. The institution creates a culture. The fact that Golter Gate is there, the fact that we have leadership that says quality of life matters. The fact that we have an institution that says the best science is team science, and that our cancer center is built on that idea of how do we create the cores and the services that will get people in the same room. And so the institution creates the lab, right?
Yeah.
This ripe lab where you can succeed. Then it's the people from there, right? So that we can call Yuman Fong in surgery, as the chair of surgery and say, we have this idea, who might work with us, right? Or we can call Dr. Salgia in medical oncology and say, we have this project and, it would probably be great to have a fellow involved. It really is about creating a culture, an environment, an institution that welcomes and nurtures this work. But then it's about the people. It's about the people.
Well said. You cite the faculty. There's this aura, though, around everybody that works here, isn't there? I mean, from the person that parks the car, the valet station, to the janitors that work here, to the secretaries that take intake calls from patients. There's sort of a special vibe around individuals that come to City of Hope. And I think that pervasive spirit really sort of fosters collaboration. I'm sure it contributes to a great extent to individuals' quality of life as well as they get treatment here.
It's absolutely. And I mentioned we do a lot of qualitative work where we interview patients and families, and I could tell you a lot of stories about the housekeeper and the valet parker and the orderly that takes a patient to radiation. I had a friend who was a colleague, a physician, who was also a patient here at City of Hope. She had transplant. She was over in the transplant unit. I had gone to see her one morning. She was doing great. Her sister was in the room. We laughed and how great she'd get out of the hospital soon. She'd been here a long time. I left the room, went over to start my day. And a couple hours later, her sister called me, please help, come quick. I walked back over thinking, what? I got over to the room and the patient had a cardiac event. And so there was this havoc, as we know, of getting this patient transferred into the ICU. So I sort of tried to help with all of that. And then after I left, the sister had been told, we don't know if she'll survive, but if she does, it's going to be a long stay in the ICU. So you need to move all of her stuff out of her room. So I finished my day. End of the day, I went back over just to see what was happening. And here was the sister. The patient was now stable. And so I thought, I want to learn from this, because what a day to go from laughing in joy to like, what? So I sat with the sister. And so I, again, in my researcher mode, he said, wow, you have really been through it today. We started laughing and talking about going home, and then this has happened. And so I said, can you help me understand something? In everything that happened today, what helped? Can you tell me one thing that we did right? And in my mind, I'm thinking, was it the nurse over on the transplant unit that explained what was happening? Was it when they got over to the ICU? Was it the physician or the nurse who were admitting her that explained now this ventilator and all of this? Like, what happened? And the sister looked at me and she said, the valet parker.
Really?
Yeah. And I said, really? I think first I said, what? And she said, oh, yeah, the valet parker was great. And so I said, oh, can you tell me about that? She said, sure. I wouldn't have made it to this day without the Valley Parker. She said, they told me I had to get all my sister's stuff. I was frantic. I didn't know if my sister was going to survive the next few hours. I had this big old cart with all this stuff. I went out the front door of the hospital, and this lovely man came up and said, can I help you? I can tell, you don't look so well. And he sat me down on this bench, and then I told him I had to load this stuff. And then I realized I didn't even use the Valley Parker. And he said, oh, no, that's fine. Just tell me where you parked. So she told me this profound story about the Valley Parker and how he listened and he was so kind and how he was, he helped her to maintain enough control that she could go back to her sister. It was a profound, I don't remember who I called, but I called somebody in administration and said, find out who trained the Valley Parkers, because they really need to be training everyone in good communication. Coming to City of Hope is about the Valley Parker and the housekeeper and the people that serve you food when you're sitting there waiting for your loved one to be in surgery. It's everyone. And if we took away those things, if we didn't have those people, you and I would not be doing the clinical care and research that we do, right? It would be a different City of Hope.
Betty, as you know, the title of the podcast is On the Edge of Breakthrough, Voices of Cancer Research here at City of Hope. A question for you. What does On the Edge of Breakthrough mean to you?
I think that really means that at City of Hope, we have the opportunity to really change lives, to change science, and to really raise the bar of what all people can expect from cancer care. And when I first started, we were doing really descriptive studies because we needed to first understand the patient perspective. So we did a lot of observational, descriptive kind of studies of just tell us, please, patients, tell us. And then after a few years, we realized we need to get on with it, right? We need to change care. And so we started doing more intervention studies where we would test a new way for supporting people with lung cancer or integrating palliative care for patients on phase 1 trials. So to me, On the Edge and breakthrough means not only delivering cancer care, but changing the entire paradigm of how cancer is treated.
Gosh, beautifully said, beautifully said. I can't think of a better note to end this on, Betty. This has been a wonderful conversation. I want to thank you so much and congratulations for all that you've done, not just for City of Hope, but for the field of palliative care and quality of life. You really are a trailblazer.
Thank you so much.
This podcast was produced in partnership with Amaze Media Lab.